All right, welcome everyone to the 4th webinar series on COVID-19, jointly organized by the Malaysian Society of Infection Control and Infectious Disease, or in short form, ICID, and Institute of Clinical Research, NIH. I am Dr. Fariza, and thank you for joining us live from social media. Before I introduce the moderator for today's session, as usual, we will remind you in regards to first the question and answer. This will be typed using the Slido X, and we will try to address as many questions as possible. For your CPD points, all frontliners, healthcare professionals, and allied health team, remember to collect your CPD points by filling up the online attendance form. In case you miss it, it will be broadcast again after the Q&A question. And please double check your email address before submitting to make sure that you receive the CPD points. The slide and notes after the session will be made available on all social media websites as well as email newsletter. The video and podcast, if you like to watch this session again, you can go to our clinical updates in COVID-19 YouTube channel or listen to our podcast channel when it is available. So this afternoon, we are indeed honored and privileged to have with us two members in Malaysia bioethics community, Dr. Liew, Houng, who will be our moderator for today's session, and Dr. Tan Hui-Siew, who will be shared with us her experience in bioethics. On behalf of my ICID and ICR NIH, I would like to thank both Dr. Liew and Dr. Tan Hui-Siew for taking the time to join us this afternoon. Now I pass the floor to Dr. Liew.
Thank you, Dr. Fariza. Thank you for your kind introduction, and good afternoon, everyone. I'm Dr. Liew Houng. I'm the moderator for this session, and it gives me great pleasure to introduce Dr. Tan Hui-Siew. She is a clinician, been in our Ministry of Health for the last 16 years, and she also has, she's a pediatrician in practice, but she also holds a master in bioethics from the Harvard University. And currently, she's concentrated her effort in establishing clinical ethics support in public hospital, which involved in the clinical ethics consultation and interprofessional ethics education. She had helped to set up the Hospital Ethics Support Service called HES and Clinical Ethics Committee in Ampang Hospital, which is operational since July last year. Dr. Tan is also the co-founder of our Malaysian bioethics community, of which she has led the editorial work for the bioethics and COVID-19 guidance for clinicians, which was published in May last year when we had the outbreak of COVID-19. And we hosted several webinars and published several writings during this period. Dr. Tan is also a member of our Malaysian Research Ethics Committee, and she has many other interests, area of interest, including public health ethics, narrative ethics, and of course, her core business in neonatal, disease, neonatal jaundice. And overall, she's a personality and a great clinical leader, I would say. And I had the pleasure to know her in COVID-19. She's one of the person that I made a new friend without ever having a physical, in-person meeting. But we have met many times in webinar. And of course, over the last year, I have enjoyed the fellowship. So without further ado, I'd like to invite now Dr. Tan to share her presentation. Dr. Tan, please.
Thanks, Dr. Liew, for your kind introduction. And okay, sorry, I think I should go back to the first slide. Okay. So yes, hi. You may call me HS. So I'm from Ampang, and I thank I kid Dr. Anusha, Dr. Myron, for inviting me to actually share some of my experiences. And thank you to Dr. Liew, which has done quite a lot of work in Sabah, also helping with the complex cases there, and the ethical issues. And definitely I congratulate MOH for the major step that we are taking to acknowledge, the ethical issues that we have during COVID-19. So I'm not a great expert, or I'm not an expert, but I think I have quite a focus into developing the field in clinical ethics, have a keen eye on identifying the problems, and my primary aim is still to support. So many of what I'm sharing today is going to be from the input and ongoing dialogues that we have had with many clinicians, and I'm grateful for having you who could share with me, open up, to share with me your challenges and also ideas how are we going to move forward. Should I read this? Yeah, okay, so you can read your own. So I will just start to share a few stories, and these cases with elements of narratives are meant for moral imagination and triggers for further conversation. So these stories are fictional, semi-fictional, and are in no way related to a particular patient. So we have a son of 75-year-old patient, unhappy of one-way transfer decision to the general wards, COVID-19, pneumonia Cat 5, day 23, transferred from ICU to the general wards as poor candidate to survive intubation in view of poor heart outcome, complicated with non-STEMI, refused bypass, NYHA class 3, but no previous ICU admission. So patients' wish were unknown. Son says, I want to go all out. So there was a new onset drop in GCS in the ward, intubated to investigate and to decide the overall goals of care. So from the managing team, they were asking who should be authorized to actually make the best decision on behalf of this patient who lacks decision-making capacity. So you would see that there might be also some ethical dilemma and also family-physician conflicts here. So another patient, 60-year-old, retired high school teacher, underlying hypertension, dyslipidemia, premorbidly independent, presented with sudden syncopal attacks. So patient was brought in, treated as ST elevation MI, deteriorated, intubated with 4 inotropic support. So patient showed some clinical improvement, but GCS is poor. So a week later, he was deteriorating, and without sedation, he was able to wince in pain. Pupils were 3 mm reactive, otherwise no cough, no corneal reflex. Family was informed that the prognosis was grim. And again, the managing team said, how do we decide if a patient is for active management or comfort care? Is it ethical to opt for conservative management? So active management means you need to go on with angiogram, hemodialysis with high risk consent. So we have also pediatric cases, a 9-year-old vegetative state due to TB meningitis, trach, ventilator dependent, almost in the ward for 5 months, and now new bout of lung infection, and CPAP was set up to SIMV mode, ventilator mode, and parents did not want to accept to step down of care. And the only non-COVID patient in the pediatric ward, which is turning to a full COVID hospital, was not able to transfer out. The attending pediatrician is no longer there. And the current one says, talking to the mother multiple times, but, they still have big hopes for her. And that was the words. And is it right to, hasten the process of trying to ask the parents to step down when they are not prepared? So if you see on the other side on the graph, there are some of the data that we have gathered, the cases that were referred to us in Hospital Ampang last year. This was last year's stats. And you see the majority of the issues will be end of life issues. So today, I speak today mindful of the groups that I identify with. So from HAS, from CEC, from Pediatric Department of Hospital Ampang, MREC, MBC, and also I'm the receiver of the healthcare system in the country, a mother and a daughter and a friend to many as well. So I hold other hats as well, clinical, research trainer, educator, NICU, PCICU experiences, administrative and policy making experiences. So again, I'm, a keen learner. I will cite the original phrases and, cite them accordingly, but I do not intend to prescribe or change any of your current policies and make no claims about what is the best test or methods. Okay, so whatever Dr. Tan says, you need to take with 2 pinches of salt. Okay, I am fully aware of how we are going to be more of a conceptual kind of discussion. While I will be sharing my observation analysis, but I can't help, to feel disappointed with the gaps that we have in evidence and literature, on a lot of all these ethical issues. So if you could relate to it or disagree to it, please, or you are disagreeing to anything that we'll be presenting, just let us know, okay? Okay, so you'll be wondering what the roles of bioethics, right? So what bioethics remain an integral part in the response of the crisis in the world. And there is a small group of us, and we hope to see that we could forge a strong sense of solidarity to be able to create awareness on the moral distress that clinicians have and encourage steps and clinicians and healthcare managers could take to support each other So I hope, we could help you to facilitate in the resolution of complex issues, conflicts, and also to enable and justify some of the safe and just practices. So when it comes to practicality of, how to actually carry on with those aims, so sometimes when you have a case, you refer to the ethics, group, and we look at it, we try to analyze, give you some recommendation, and which are acceptable or feasible, and the clinician will make the final decision. So we remain advisory, and our recommendation are not binding. So we could sometimes sit down and chat and facilitate some of the conversations between the teams and also family members. And also we hope to actually facilitate policy making to help deliberate on the ethical aspects, interprofessional education remain main part of our work, like what we are doing now today. And you see some of us will be doing a bit of advocacy work as well. So by considering the clinical, legal, and social cultural borders, and that's where we try to actually draw the boundaries, where are the areas which are acceptable, which are the areas which are gray, and when there are choices which are equally problematic, we could only aim to actually seek the best one, okay? So these are the writings, as what Dr. Liew has mentioned, that something that we felt that it was a need that clinicians might want some guidance, and we have tried to respond the best we could, based on the input that we have gathered from the ground. So what we are going to be doing today might have some overlaps with some of the talks that I've been giving. So we will just try to focus today on who, what, when, how of DNR and end-of-life decision-making. Okay, so what to do in the event of conflicts. And again, the discussion will involve more of a bedside clinical micro level. What would be your duties? Okay, what would be your duties to plan, to care, and what we should be doing, but not at more of the macro level, such as resource allocation, triaging, of which the principles might actually conflict at different points. Okay, so okay, so let's start off with asking if you could just log on, if you have another phone, that you log on pollev.com, and you just type in who is you, time 499, and if you could just tell us, what do you think? Should decision making for DNR be the same for COVID-19 and non-COVID-19 patients? So it's just a yes, no, depends, and okay, so if would you able to, if not, we'll, oh, okay, yes. So if you anonymous, don't worry. So this is something we do, sometimes, because there might not be just one right answer, and it's nice to see what everybody thinks about, should it be the same, or it really depends on, what are we talking about, so but let's focus on DNR. Okay, so so sorry. Okay, so we move on. Okay, so I think everybody would be able to see the results. Most of you, 60% say yes. Okay, no, 5%, 1/3 would say depends. Okay. So one thing we need to know, that the complexity of dying in the modern era is we can actually kind of keep the patient alive for on and on, and life and death is not anymore a two-stage life cycle. Okay, so many are on borrowed time, and they just go on, and just because medicine could. Okay, so that's this kind of problems that we have now. So I do believe that self-empowerment and generally public awareness on the importance to having conversation on dying is still lacking. Similarly, there are many quantitative studies that have been trying to determine what the patient would want when it comes to dying. Just one example whether they prefer to die, at home, and also that the associated barriers. And Hospice Malaysia has tried in 2016 to show that out of the 600 people surveyed, even though we know 50% of patients die in the hospital, we do not know how much die at home, but it shows that 60% of them would rather die at home. And when we ask why do they think that they were not able to, if there is a reason they were not able to, and many have quoted interference by family members, and they feel maybe the care will be better in the hospital. Definitely there's a small percentage talking about medical professionals, interference of not able to die at home. So it's interesting and not surprising to see some of the influences from, different aspects. And I do believe that some clinicians might not still feel confident with dealing with death. They are worried about family expectations, legal implications, and we are still seeing patients with the capacity that has been asking for AOR discharge just to try to be at home. It's clearer for cancer patients the way that we manage, but not many that has like advanced NCDs and comorbids, and so we could use more of these studies to actually know and understand Malaysian better, but always go for stories as well, qualitative reports, and they will be more insightful. And I just shared two, and to show you how different we are and similar we are at the same time. A Chinese lady with breast cancer advanced stage, care for inpatient, her 5-year-old decided to help her to comb her hair and maintain this routine until the day she died. So something that created both fulfillment for both the mother and son. And the same thing that happened to a Malay lady, 40-year-old, and she has decided that, she has young children, and she decided to actually stay in the hospital. And, at the end, at the last moment, she wished to take a shower, and she wished to dress up clean and to have a clean image before Allah, and her husband agreed to assist her. And her husband helped to comb her hair as well. And that in that sense, she actually was able to find peace and calm moments. And we hope these are the way that we should be dying, the calm moments that we could achieve and attain by every single person, when the day comes. So if you see that it doesn't matter, that social cultural backgrounds that we come from, we need to consider every time when we see a patient, but the thing is, like, it's not enough for us to be competent about how much you know about a culture or a faith, or how humble you think that you do not know enough. But for every person that you see, the values and preference that they might hold individually might or might not be related to their social cultural background, their faith, their stated faith, their upbringing, education, experiences, or even from the hospital experiences, their own identity, their relation to others. And remember that deep down, the universal emotions and sentiments actually hold us the same, like what I've shared with the stories. And so always do not assume, you need to get your psychosocial history, story, try to understand the how and why, and put yourself through that different lens, putting yourself in their shoes. So these are the challenges and barriers that I find that would be potential areas to actually have more future research, the challenges and barriers we have when it comes to end of life decision, so most of it we have actually kind of touched on. Also, just to mention the lack of support and skills training for clinicians to actually feel more comfortable. They feel that they are supported in terms of ethical support, legal support, psychosocial support as well. So, and when COVID-19 came, with what I've been giving you as a background, COVID-19 gives us that time pressure. They give us critical bedside decisions to make on top of that time pressure. And there are many changes in the practice that we have, because we now have the whole public health crisis within the walls of the hospitals. You need to make sure that the disease is contained, so the infection control barriers is the main thing that is part of our care nowadays. So it definitely has strained many of us to the max. And, most of the time we are dealing it alone and with difficult decision making, and conversation with patients' families. And, and there are many studies which are ongoing about the psychological impact and also the moral distress that we are facing. So my job today is trying to find areas which are clear, areas that are clear, steps that we could actually take, of course, there are many more other gray areas. So first thing is actually important for us to be clear about the definition terminology. So when we talk about DNA CPR, I think it denotes more specifically of CPR. And there are also literature talking about A&D, allow natural death, and this would probably reflects better end of life philosophy of providing comfort rather than cure, but it's not commonly used in Malaysia. So I think DNR, the term itself, I think it's very familiar to us, it's very common to us. It may represent resuscitation steps and also include other life-sustaining therapy, such as dialysis. So I think it is important that we don't view DNR order as a blanket decision for conservative management, not for intubation, chest compression, every single, treatment like dialysis or blood transfusion. So it's important to actually look at DNR, not in isolation from other aspects of end-of-life care. So we need to try and focus a discussion around, disclosure first, breaking that bad news, aligning expectations, and see how far we could actually do still a shared decision making during COVID, and to focus on what is the overall goals of care for the patient. It's good to actually specify what is involved in the decision and so communication. So I would just share this because I think that today's talk is not about what are your duties, because it's very clear that your duty of care as a clinician, as a doctor during COVID-19 is to focus on the individual patient, but at the same time to recognize, the need for a public health containment of the pandemic. So I think we need to know that duties are there and we couldn't run away. It's a prima facie duty, something that in front of you that you need, the first thing you need to do. Of course, if there are any other obligations or principles that come into play, and that's where we will be thinking whether we could actually kind of have a second option. Okay, so so when it comes to duty of care, so CPR, the one part of the area where we are talking about DNR today, I think the safety, timing, effectiveness of CPR during COVID-19 cannot be more emphasized during this period. And knowing how the situation are at the front line, like in the ED, I believe that we need to ensure that safety always comes first. So Dr. Liew is here, and I think he would totally agree that you need to make sure that safety comes first. And we could allow a bit of, I think it's okay to actually allow slight delay because of that. Okay, so you need to don on your PPE, you need to find a suitable place, and you need to confirm your code status. So those delays are still in a way acceptable, but definitely you could not be justifying your delay because of the reason that you don't have a bed, that there are not enough bed, you're not going to resusc the patient, or you're looking at it's a COVID-19 patient, you decided not to resusc, or because of the social status. And because this is the reason, because we know delays can still be reduced and anticipated, in a way that if we plan it earlier and we know that this patient is going to have an arrest, and we need to make sure that our PP is always there, where should we resusc a patient if there is one. And again, there's a duty for us to actually plan this training for different scenarios to ensure that CPR is effective. So even for those with advanced comorbids and suspected COVID, and you do not know their wishes, they have no discussions before on what are their goals, and the split seconds decision must still be made, and you still need to make sure that timely resuscitation is provided, if required. So let's go to the first question: who decides? I think this is going to be a very common question that you always get. Who's going to decide? And I think I'll put patient first, like if the patient is there, okay? So that's what bioethics will say, patient first, okay? So, okay, let's see how it is not so as easy as we think as well, during COVID-19. Whether, some would say this is a Western concept and whether it's relevant during COVID, I would say that it is relevant and definitely it's compromised to a certain extent. We know that respect for autonomy is something that they have the right to refuse, to say no, or to even waive to a family or physician. And expanded kind of definition for autonomy also includes relational autonomy, where you make your decision based on your relation to others. Okay, so nobody stands alone. Most of the time we are making decisions because of others, our family members, and during COVID-19, this delicate balance of how much a patient should decide. Okay. culturally or situationally, whatever it is, it has definitely been compromised to a certain extent for both COVID-19 and non-COVID-19 patients. So we need to know there's a legal boundary in here remain, the Public Health Act, which gives the MOH, the PG, the power to set what needs to be done in terms of isolation, quarantine, testing, and treatment to contain the pandemic. So I think in terms of that utilitarian and paternalistic approach during a public health crisis is ethically justified for the safety of all. But you need to remember it's just this isolation, quarantine, testing, and treatment. So it's just based on trying to contain the pandemic, not any other parts of clinical care. Okay, so but it's still important to actually balance that population need and to make sure that excessive burdens and harms are not imposed to individuals in terms of their well-being and health in the name of public utility. So one way is actually to talk about personalism and to be reminded that we still need to respect the person in front of you, their individual values as best as we could, and even during public health crises, those who are dying. And I think their wishes need to be honored as best as we could within that confined public health, interests and measures. And I think the first thing we need to make sure that to give them information. I think it is right for them to have the information where they need to be well informed what's going on. You need to keep them well informed and to make sure that they reduce their distress. And also I think it's their right to know. Okay. So your part, you need to make sure that you are doing your best. You are not you are following the SOP, you are following the evidence-based medicine accordingly for COVID-19. Okay, so there are other things as well that you might want to consider if a person which is dying, that he wants to refuse care, whether you would consider to actually kind of trying to honor that wish. So, but if the patient is able to make some, decision, then we look at capacity. And again, when capacity, it's always whether the patient would be able to communicate a choice, understand your information, appreciate the situation, and, is rational about what he's choosing, but always be mindful that sometimes incapacitation can be temporary because of the state of delirium, fever, hypoxia, uremia, sedation, or stroke, or even fear, anxiety. And I think autonomy itself also, you need to know, what are the influences to that decision making, that free agent when he's not free agent most of the time. Definitely there's influences in terms of the stress that he's facing, his family, the relationship that you have with him, and the power differences that most of the time we are not aware about when we are in a clinic or, when the patient is in front of us, and also other social determinants in terms of his social background, educational level. And if we are able to, I know this is definitely much compromised as well. I think we need to be reminded that, most medical decision making still need that shared, approach. And now we are having COVID-19 and, we have the legal boundaries. So how much we could actually allow that shared decision making, because I think that shared decision making is important to build trust, to maintain the trust, to allow a bit of self-determination, the right to information, and you still have a bit of authority in terms of trying to recommend the best treatment for the patient. So I think with this in mind, and if you have a patient in front of you now, in the ED, and you would be looking at, if the patient has the capacity, you ask him or her, this is what is going on, and you have COVID-19, we are going to admit you here, and this is what we are going to do for you. But if let's say they came in with, in an incapacitated situation, and you'll be locating what would be their wishes. So I think it's not a common practice yet in Malaysia, but I think we are trying to progress and trying to make sure that patient has these wishes being noted down somewhere, has been discussed about the goals of care for those with life limiting disease, those with advanced comorbids. And if you fail to find this, the next thing will be turning to the family members for a substituted judgment. Okay, so we'll go about substituted judgment later on. But just bear in mind that, for now, Malaysia doesn't have a legal statute for it, and probably given the poor public, awareness for it. But remember, it could still be recognized if you're worried that, there's an AD in front of you, and whether you could actually honor it. Okay, so if there's such a case arises for judicial review, they could still reference it to the common law and also the local professional code of ethics. MMC has mentioned about AD in their code of professional conduct, and their consent for treatment has actually stated on written AD. Okay, so AD can be used, but it cannot be applied to illegal activities like euthanasia and termination of pregnancy. You still need to look whether it's relevant, whether it's valid in terms of the clinical circumstances. And there is also the priority for professional judgment in emergency scenario and also circumstances which are uncertain. I think that would apply during COVID-19. Okay, so if you need more information about AD, end of life care, okay, you could always go back to the professional guidelines as listed here to actually guide you. So these are the things that we would say the guideline is there, so it's best that you look at it, okay? So if you're asking about I've heard about advanced care planning and AD, what's the difference? And AD will take, I think ages for it to be there in terms of getting the legal, support for it. AD in other countries is probably still also focused on more instructive medical care, whether you want this care or you most of the time it's about, care that you do not wish to have. Okay, so it's very individualistic as well. So ACP is something that Malaysians are using. Malaysian clinicians, the palliative care physicians are using, is something that might actually include some of the instructive, medical wishes, but also they have more focus on values, wishes, things that matter to the patient the most, the burdens that they are willing to accept, who they want to actually be the one to make decision for them. And so it considers a bit more multicultural and also the local context. So when it comes now to the surrogate decision making, if the patient doesn't have we do not know what he wants, and there's nothing that we could fall on, then it will be the next of kin. But again, surrogate decision making could technically or ethically could be anyone, okay, in a way, so we don't have something that in the country to say that, legally, who is the first person that should be making decision for you. That hierarchy is not there. So the best thing we have is Mental Health Act, where they actually listed out spouse, children, parents, and siblings. But again, it's not what hierarchy that we have. And we don't have the legal regulation on having an act where you have the enduring or lasting power of attorney, where someone could actually make a decision making for you in the event that you are permanently incapacitated. So we do not have that act. Okay, so next of kin is still socially and professionally recognized, not always the best one. But again, that's all we have, and we need to support them. We need to make sure that they are able to demonstrate qualities like, the capacity, they are available, and they are willing to serve and familiar with the patient's preference. So when it comes to substituted judgment, it just means that, the surrogate decision making, we try as best as they could, to think about what the patient would have wanted if she or he were competent to do so. So you are trying to think on behalf of the patient. And, it may not still be perfect, because it's definitely could be quite subjective, and it is, surrogates might not know, patients might change their mind, and patients might actually want the family input, and family might have bias or any other conflict of interest. So, and also it might actually conflict with what you think is the best for the patient. So, so that's best substituted judgment. So back to COVID-19. So I think this process, that the patient autonomy is a bit compromised, shared decision making is compromised, and family wishes may not be met, even you are not able to actually see them, as best as you could, very short family briefings, most of the time on the phone, you try your best through the video. So I think it's definitely very stressful for everyone. So I think that sense you have that duty, that compensatory kind of duty to actually make sure that you're doing your best. Okay, you still you try your best to respect the person and to understand that distress that they have, and so try to build your relationship early. In the ED itself, try to recognize the emotion and values, try to build consent, senses as best as you could. So this is something that we, I think I've tried to kind of propose, for who decides during a DNR and for the purpose of both COVID and non-COVID patients. So, so it's something to do, just a guide, where that who decides, okay? So it might not be perfect again, okay? So you could have a look, if the patient has capacity, yes, go ahead. If no, you look at the surrogates, and if they are not there, then you definitely need to go to try and consult the hospital committees. But if there is some wishes, there's known, especially for those with advanced comorbids, and whether you think it's okay to follow their wishes. And if there is no wishes known, then it's back to best interest. Okay, so best interest, I think for COVID-19, I think that is something that we use definitely during even any other medical decision making when the patient's wishes is not there. And the calculation that we use to actually decide depends on the survival rates, the prognosis, the quality of life, the benefits, harms, and burdens of that intervention. So we could actually include as well known values and patient goals. So it doesn't need to be just medical, decision making. So the best interests can be in the best thing that we have, but again, it could be vague. It could be difficult to do calculation. And also you might not be doing what patient would have wanted you to do. Okay, so and again, he's incapacitated, so if there's no way for you to find out anymore. But there are a lot of things that we might not be able to consider, so that's best interest. So when it comes to best interest and DNR, so the word futility will come in. Okay, so we are talking about if the treatment will be non-beneficial or would be causing great harms or burden. Okay, so we're going back to criteria of futility. So when you look at futility, there's a few things which are clear. Okay, so when you talk about physiological futility, you're talking about imminent death. So meaning the patient's vitals are crashing despite maximum support. And when you talk about a little bit less than that, not so bad, so it's medical futility. It depends quantitatively if you think that the treatment will most likely not achieve a benefit, or qualitatively not giving the overall benefit to the patient. So you could think of quantitative as the likelihood of achieving that success, and qualitative is more of overall qualitative wise, does it really give back the patient the quality of life, and that the goals that you are hoping to achieve. So nowadays we are, because it's so difficult to actually define. So nowadays we are looking at futility as something that you should be going through as a process-based approach. So what happens? So we don't throw the ball back to the patient, but again, patients are the experts on their goals and preference, and clinicians are the experts on whether those treatment will achieve those goals and preference. And I could share with you more if you are interested to know about faith-based bioethics perspective on futility, in another session. So, okay, so we are going to go through another, poll. Hopefully you could actually share your answers. Okay, so because now we are going into the more controversial part, and when the time comes, we are looking at futility, our actions or omissions, a form of killing or allowing to die. So how do we differentiate the both? And if I wish that we have more time and to have more examples, and we could actually kind of discuss about them. So today we'll be scraping the surface on basic principles. But I think, are you ready? So here is a thought experiment. And let's say Aunt Mary Lim is dying of an incurable disease. So her family and her doctors have agreed to withdraw her ventilator in the morning, knowing that she would die quickly. But her greedy nephew Joe has seen her view and knows that he will be cut off of the inheritance unless she dies before midnight. So that evening he sneaks into the ICU, turns off the ventilator. So the nephew actually performs exactly the same acts the doctors would have done the following morning. So was the nephew's act permissible or defensible? Okay, so how can we say that the nephew killed her, but the doctors merely allowed her to die? Let's say if that's your answer. So let's see if what would you answer. The first question would be the easier one, was what the nephew has done is right. Did he just allowing her to die or killing her? Okay. Was the nephew's act defensible? Means will he not get into jail, I suppose, has he committed a homicide? first degree. It looks like maybe a first degree homicide here, right? Okay, so so 85% of you say no. Some of you say yes. Okay. Yeah, it definitely is not as easy as we think, you know, we're just looking at it because, you know, the doctors will be doing the same the next day. And, you know, the next question would be, let's say the 90% of you who said that he killed her. And why do we say that he killed her, but the doctors are not killing her and the doctors are just merely allowing her to die? And so if you would, you know, try and type out your answers, and it will be quite interesting to find out from each other. You know, intent is different, planned, unplanned. Yep. Nephew had intention for death for personal gain. Doctors has no personal gain. Intention, yes. Intentions are different. Okay. Or you disagree that, you know, it's the both are killing the patient, or okay, murder with intention. So intention is the most difficult thing to actually kind of prove most of the time, the things that we do, you know, same actions, but different intention. Macam mana, okay? Motives, intention, okay. So doctors hold ethical rights, okay. So, to kill, or nephew had intention to kill, okay. So yes, intent is the issue, okay. So okay, so we'll stop here. So yes, so intent is the most important thing. So it's about what is your intention at that point of time, and whether other effects that you see is just a side effects, okay? We say a merely foreseen, you know, it's going to happen, it might happen, but you had no choice because you need to actually achieve, you know, a good end for a patient. So before we actually go into double effect, which is a principle that we use in such situation. So I like Andrew Maggie because he kind of give another analogy. You know, if we withdraw a life-saving treatment, do we cause death or allow the patient to die? So he says that when you flip a light switch, the lights go off. When you flip the ventilator switch, the patient dies. But again, you know, the ventilator was there to actually stop the dying process. So we are giving the ventilator breath. So we are just stopping that action and the patient dies from his disease. So does it sound the same or not the same? Okay, so that is his point of view. You know, it's something which was not there, but we gave the patient something to help, and you know, and we stop this action, and the patient dies from his disease. So okay, so you could kind of apply it to other situations. You know, like in extubation or stopping the dialysis. Okay. So double effect is actually a doctrine or a principle that says that action might be permissible, even though it's causing serious harm, such as the death of a human, if it's a side effect of promoting something else. You're trying to promote a good end. Okay, so that there is kind of 5 criteria that you need to fulfill. So let's say if you give an example of trying to relieve pain with morphine. So if your intention was to actually relieve pain, and a good intention must be there. So your intention is good. Okay, so you want to relieve pain, but because of the disease will be overpowering the patient who is feeling more comfortable, you know, that the patient might actually die in the process. And you know, so you're trying to aim for that relieving of pain, and at the same time, the patient actually died. Okay, rather than you are trying to to trying to stop the pain by killing the patient. Okay, so you can't be saying that I'm trying to relieve the pain by killing the patient. So there are, an essay actually was wrote up by one doctor anonymous, where you can read about it, like, Debbie is over, where he looked at the patient and the patient was struggling, and he decided to just give her a dose of high dose morphine. And, he says that, okay, you feel comfortable now. So he's trying what he did was kill the patient so that to relieve the pain of the patient. So that is not the right way. So again, these 5 criteria is something that we can remember. The act must be morally good. Good effects intended, bad effect is merely foreseen, and the bad effect is not the means to the good effect. And again, the good must outweigh the bad. Okay, so, but of course there are opponents to it. They say, in that sense, are we talking about this is the moral free zone that we don't have to be responsible for our actions, whether they're intended or not, and why should it be different in this context, and sometimes we tend to worry about what are your intentions of the families, and they are not always pure. We wouldn't know. Okay, and there is Anton Chekhov, which is the the literary giant who writes about 3 brothers, and they are trying to they have a father which is quite an evil person, and whenever there is someone in the family who has long been ill, hopelessly ill, there come painful moments when all timidly, secretly at the bottom of their hearts long for his death. Okay, so I think that is something that's being fed to me as well on the ground, that's saying that sometimes they do not know the intention of the family when so again, when the patient's voice is not there, it's going to be very hard for us to know what to do. Okay, so, and the next thing is about like withdrawing, withholding. I think this is much clearer, easier to understand, and there is no morally significant difference between the both. And you might actually even overtrip for being withholding, because you're not giving, and also not giving the chance to remove the uncertainty about prognosis. So sometimes it's maybe it's better to actually withdraw. But again, if you look at this pack of dialysate, and if it has finished, and the next thing you'll be thinking whether I should put on a new bag. Okay, so if you don't put on a new bag, does it mean that you are withholding, or are you withdrawing dialysis? So sometimes it's just the same, it's the same. Okay, so but emotionally it feels definitely so much different, and that is something that we need to recognize, because these are what the clinicians and also the nurses are feeling. We could not ignore or dismiss it. So in the end of the day, it goes back also, you need to assess the benefit and burdens of that care, whether it's for the best interest of the patient, is that what he wants in terms of his goals, and you need to be honest, and you need to have that open conversation with the family, even though it's the first time we are doing it during COVID-19, and that is where you need to just be open about the struggle that you have. So if you are interested to know about the emotional struggles of a physician in terms of uncertainties, letting go, or how we could still maintain hope for patients' families, these are some of the books or articles that you could go to. So again, this is now COVID-19. So would you be able to describe the feelings or challenges that you have faced during this 1 year? Just 1-2 words, what is the one thing that popped up in your mind in terms of the challenges that we are facing? Okay, it's okay if we can move on, if you don't have, so that we could just skip this. So, okay, so the timing and circumstances, again, we know it's COVID-19, we have the uncertainties, we have resources that we need to juggle, we need to mobilize, and also the public health interest, as we have mentioned. So many patients with, advanced comorbids, definitely, previously it was not explored before. We do not know what they want. And we say that whether the families are ready for us when we are going to DNR, are we prepared? Do we know what to do? And how are we going to make sure that what we are doing is right, okay? So I think how to go about it is the next point, where we are trying to see whether we could bring you through steps that you could actually, carry out. First thing, you have those triggers that you feel that you're looking at a patient which would not be benefiting from the intensive care or resuscitation. And that's where you need to actually try and assess whether they meet with the indication, whether you have the appropriate level of decision making, followed by disclose and discuss with the family as early as possible. And once the family is ready, you inform, you manage, and resolve if there are any conflicts. So you need to try and align expectation, maintain the trust, and allow some shared decision making. So when the triggers come in, usually you look at patient which has poor response to current treatment, disease progression with severe major organ dysfunction, failure, repeated hospitalization, or they actually have the wishes. So you assess for indication for DNR end of life. Look at futility, again, like what we have covered: physiological futility, medical futility. Is it because of the quality of life, or is it what the burden and the risk of the therapy you are trying to consider is more than what they are able to accept? Then the next thing you'll be asking whether the level of decision making, am I at the right position to make that decision? Okay, so this is end of life. This is like, death itself. So if you have the time, I think team-based consensus is important. Shared decision-making, if you could, with the family. Under time pressure, I think decision must be done at a certain level of, experienced specialists, senior members, and communicated empathically to the family members. And the preconditions are, again, you must have the assessment. You must make sure that you have disclosed and family has started to actually accept and their expectations align. So when you want to break bad news, there are many algorithms which are there. You could use spikes, okay? And it's a very easy setup: perception, invitation, knowledge, empathize and explore, and summarize and strategize. You could use these spikes for breaking bad news when it's a grave diagnosis, when there are clinical deterioration, presence of futility, imminent death. When it comes to the next stage where you say, okay, maybe there's time that we are going to discuss on goals of care. So goals of care is basically based on, we are going to discuss on the disease trajectory. You're talking about patients' goals and values, the risks and burdens of each intervention, and you are going to decide on resuscitation, ceiling of care, comfort measures. Okay, so some units and disciplines are actually quite familiar with goals of care, okay, like the oncology or the palliative care physicians. But I think many of us has been doing similar conversation. So I think it's important to have that skill, in every discipline, including patients, patients with advanced NCDs. And the common question that we used to get also is actually whether it's okay to just inform some of the decision. And it's right to feel that it's better that we just inform. So that's where we are looking at informed assent. Okay, just assent means to agree or give permission, of which written authorization is not required, but you still need to document. This intervention could be minor ones, some things are just, that's the best thing to do, but it could be for resuscitation, very impactful decision, critical decision, life-sustaining therapy. And it's clear that when it's clear that you think that it's not going to be beneficial and you are trying to give the option to proceed or withhold, might actually cause more confusion, emotional burden, and guilt for the family. So as a clinician, you need to, kind of make that judgment once you know the patient and family better. Okay, so but overall, we do not think that DNR withholding life-sustaining treatment needs a stamp or signature, for the clear reason that the emotional burden that we are imposing on families, and they will be thinking they are the ones who have killed their mother or father, So I think that we need to be very careful and tactful and sensitive about this part. Okay, so when we have done the best that we could to discuss the next thing, to implement the necessary management plan. Just make sure that you respect the person all the time, maintain their dignity, again, be empathetic with the family, consider agreed plans for goals of care, try to provide care that maximize comfort, and also consider compassionate care steps and psychosocial spiritual support, allow visitation and saying goodbyes. Again, document your decision discussion, inform your teams, ensure that everybody knows and everybody is on the same plans, debrief them if you need to, audit your M&Ms, and again, regular review of the process that you have. And so when you have disagreement, again, you go back and discuss with the family, and you need to involve the consultants, the HOD, to arbitrate, and if you need to seek for administrative, MAC, or ethics consultation or facilitation. You need to respect. Sometimes they need they need some intervention to actually have that closure. So you just assure them that maximum effort and comfort has been provided. So what happens is when you have a dilemma, everybody is disagreeing, and that's where it comes to the clinical ethics, where we try and analyze through this framework. And at the same time, we'll be, looking at whether we have actually connect enough with the patient or family in front of you, whether, I think the sitting down and chat to apologize, sometimes to the shortcomings that we are having, the crisis that we are having, and, and asking how he or she is going through, and that really matters. Okay, so what matters the most to the patient, might not be something that you think matters to the patient, but it matters to him or the family, and things that they view, some of the things that we are doing and the way that we are viewing things might be different, and we need to be acknowledging that. But again, most of the time, most of the cases of dilemma, there is no easy solution. We are not solving. We try the best to actually resolve, try and find meaning for those that are experiencing loss, try to find meaning those that are conflicted, okay? So if we have some time, okay, so if I could just share this, we are finishing now. I could just share the last story, if you allow me. So this is a narrative which was written by Lisa Colley. So this is where when she was just a resident, and she was writing about 9 grueling rounds of discussion. The healthcare team won the battle in a victory that bore a frightening resemblance to an ultimatum. And Miss S. sons agreed to sign DNR order for their 70-year-old mother. I chalk up the nauseated feeling in the pit of my stomach to my inexperience in the field. So we had stripped this family of a choice and left them with no option but palliative care. Medicine is not just about treating illness by attending attending means probably a specialist, and it can often involve appreciating the necessity to say no. So Miss S died the following afternoon. So later on, when a few years later, I was visited by the haunting memory of that, I rushed quickly to find the respiratory therapist providing PPB to Mr. M. So Mr. M is a 79-year-old man with a history of ESRF, coronary artery disease, and dementia. So he had been admitted 2 days earlier with signs of pulmonary edema. So despite appropriate treatment, he had been found by his nurse to be somnolent, tachypnic, and she had contacted the nephrology and ICU team for urgent assessment. So chaos swirled around Mr. M's bed as frantic measures were taken to support his oxygen needs, and his expression was tired, vacant, his bloated frame stretched by the mounting fluid in his tissue. So transferring Mr. M to the ICU for invasive life-sustaining therapy would be a temporary solution for the irreversible damage from his long-standing disease, which is an organ failure. So while his son sat Asian-faced in the hallway, Mr. M's wife stood anxiously over her husband, whispering promises of his imminent recovery and reminding him of his enduring strength for fighting his disease. So anticipating a difficult road ahead, I called my senior resident, and we huddled in a nearby conference room with Miss Anne and her son to discuss the next step in his care. My senior resident apologized for the late hour and the hastened discussion before gently relaying the facts to Mr. M's critical status and his option for life-sustaining treatment, and reminding his family of his poor prognosis. So this is in the ED. And through tears, Miss M asked the same question I had now heard many family members ask: why can't we start dialysis now? Why can't we continue breathing for him? And we gave her the same answer. And there's just no point. And after a moment's pause, my senior resident turned to the wife and son and said, "Tell me about Mr. M." It was such a simple question, yet it empowered the family, opening the door to a wealth of information critical to understanding the man who was awaiting someone else's decision about his fate. So Mr. M's family welcomed the opportunity to allow him pass a seat at the table, and Miss M laughed as she thought about his obsession with fishing and European cars his sons described about his adventurous trips through Italy. And Miss M and her son smiled sadly at one another at some point later, as if suddenly recognizing how much Mr. M has changed over the past few years. And my senior resident described the reasons why we are avoiding invasive treatment, discussed the cost of comfort, and asked whether that was what Mr. M would want. And Miss M and her son quietly digested this info, and with tears streaming down their faces, they nodded in agreement. So I think you see that there are different situations, but again, you'll be asking who is this person in front of you, and you want to keep the family reminded about, like, what would he have wanted, how he would have, wish at this point of time, and to actually have that patient at the seat, having a seat at the table is the best thing that we could have. Okay, so that's conclusion would be, there are definitely rooms to grow in terms of end of life decision making and care in Malaysia. And during the COVID-19 crisis, it's just important to follow the right steps, the steps that and to make sure that there's adequate level of decision making for DNR. definitely there's duty to care and also duty to plan as well. So try to support each other, listen, engage, and connect with your colleagues and patient family. And again, you know, that medical humility that we need to know that we have that limitation, we know the uncertainties and there, and consult and seek help if you need to. So, you know, it's very heartwarming to know that MOH has actually acknowledged the ethical struggles, that issues and struggles that we have. And these are some of the drafts that has been, you know, discussed and, you know, written up by many clinicians. And we hope that it will be released and shared with many. So if you have any ethical dilemma, dispute, or even legal concerns, and this, I would say, would be the sum of the groups or agency that you could actually approach. Okay, when it comes to legal professional ethics, you know, definitely the MMC or the Bahagian Amalan Perubatan. You know, if you are talking about clinical ethics, it will be in Ampang. UITM has as well. You know, you have one online consultation service for COVID-19, which is represented by a few from UITM, IJN. You could equally utilize that, and also some of us which are doing clinical ethics work as well at Ipoh, Sabah, Manjung, Selayang. So that's my last slide. Okay, so thanks.
Okay, thank you very much, Dr. Tan. Thank you very much, Hui Siu, for your talk. A very comprehensive talk, but I think you managed to take us through, you know, in a very stepwise approach of what is this issue on do not resuscitate. And I think, you know, even though the talk is in the context of the COVID-19 pandemic, but I think as what you have mentioned, you know, these are issues that we face, you know, before COVID-19, and certainly after COVID-19, which I believe at some point COVID-19 will go away, and we still have to face with this reality that, you know, our patients, you know, will have illnesses that we have done our best. And of course, you know, despite our best effort, we don't cure all. And there are times when we have to recognize that the care of the patient has to transcend beyond the curative agenda. And I think you know, what you shared with us is important. It's not just for COVID-19. With that, I think I will move to the questions. We have quite a good few questions. Perhaps we'll start with this one here. I believe this is from a doctor from the emergency. If a COVID-19 patients or their surrogates may want all treatment, even if futile, are we physicians legally liable if we do not provide it?
Okay, is this Dr. Muzaffar from Sabah? Okay, so again, when it comes to liability, you know, the law is not much that is being released, or, you know, guidance from MMC or even some of the medical societies about, like, you know, are we protected if you're going to do something, you know, like in the UK, so they have these issues about like triaging, and what if we make decisions and you know, that because of time pressure, and, you know, we need to actually save the most lives, you know, and family will be disputing and saying that, you know, so the one thing that we need to have is actually a clear and transparent flow in the beginning. And we need to make sure that that flow, you know, some countries actually make sure that the public is involved, you know. So let's say we have a crisis as a society, we need to decide this is who we are going to save, you know. And you know, those things are not there. Okay, those things are not there. So it's going to be a very distressing bedside, you know, decisions that you make. And, you know, when you, but again, you know, whether are you doing it safely? Are you sure that, you know, you should be consulting someone? Are you sure that, you know, the prognostic assessment has been done correctly, you know? And I think those things, what we are not having, and the things that we have would be more communication. I would say that if you want to try and avoid to get into that trouble at the end of the day or post-COVID, and I think it's important to actually start to converse and, you know, break the bad news early and tell the families, you know, we are looking at your father. He looks in a very bad state, and you know, we are not sure whether he will make it or not. You know, prepare them and telling them that you are trying your best. And I think family would be appreciative if they know that their family, their loved ones has been receiving the best care. You know, that communication to let them know that you have been doing your best. And I think that communication is always the problem, that if we don't achieve that, that's how we actually get into trouble. You know, it's not about whether you have done the right thing or not. It's just about how they perceive what has been given or not being provided. And again, when you reach the court, is a legal different kind of game. Okay, it's the games of the lawyers, and we know that we don't have strong defense lawyers that will protect whatever good thing or right thing you're doing at this point of time. And I think you need to be aware that, you know, you don't get caught up with that legal kind of fear too much as well.
Yeah, well, I was reading that question, and I read it, you know, at least 2 times, you know, to try to understand the question behind the question. And I would like to rephrase it in a way that, of course, the question is about COVID-19, but I suppose if we have in the emergency department, that when we have somebody coming in with a very serious infection, you know, like say any pneumonia, a patient who comes in with a very, very bad pneumonia and has respiratory failure. And emergency physicians often face some of this dilemma. If the patient has, let's say, no previous diseases, you know, somebody who is claimed to be healthy versus somebody who has had a very chronic, very debilitating, you know, illness and coming in with a pneumonia, you know, would that change the context in terms of how we approach patients, you know, in terms of not resuscitation and you know, discussion on the, you know, life issues? Would that change? You know, if we don't talk about COVID-19, we talk about any serious infection.
So, so you're saying that it would be almost the same dispute that we might be facing pre-COVID as well. Am I right?
Yeah.
And I would say that if you are not able to assess, you know, fully what are the goals, or, you know, you are not able to assess what would be the prognosis for the patient in front of you. And I think that the first step you do is actually to provide that care. And I think there's no wrong with that. And you know, it doesn't mean that if you are going to go active at the beginning, that you're going to go active until the end. So sometimes there might not have that room to actually discuss, or, you know, to think about what should be done at the ED, you know, you still need to proceed. But so if you are going to get to, like, you know, discuss again and again, you are facing, you know, not refractory, but, you know, continuation of that dispute or disagreement, then you need to actually move forward. You need to actually kind of consider to involve the ethics committee, or, you know, the MAC, or, you know, whatever, you know, support system that you have at your hospital to actually try and resolve that conflict. And, you know, sometimes when we actually sit down, we find that different parties have different positions, but when you look at it, you might be able to actually achieve that common agreement or common interests, you know, that I think, you know, trying to focus on the patient rather than what the family wants. And, you know, sometimes they have a lot of guilt that comes and baggage that comes with them as well. And other times are just misunderstanding of you know, what they know or they not.
Thank you for that. So I think we can move to the next question. There's a question here, which is, what is the legal aspect and the, hold a minute, let me see. Oh no, we've taken that question. So the next question here is, here you are. What's the legal aspect and ethical issues if non-infectious disease physicians treat COVID-19 patients? It's a bit different from the main topic of the day, which is about DNR and EOL. Whether would you want to make?
I think we could answer. So, Dr. Liew, do you treat COVID-19 patients? You're a cardiologist.
I don't treat the COVID-19 patients alone. I treat them usually when they have other problems with a heart problem. You know, I'm a cardiologist. So, but I understand this situation may arise in some hospital, you know, when there are only 1 or 2 clinicians, whether it is a public hospital or a private hospital even. I wonder whether you have any experience handling or getting consults for this issue.
That this is definitely something that has been asking from the beginning. So different kind of questions would come out, like, you know, I'm not the ID, or I'm not the public hospitals, or I'm old, or, you know, kind of, there are many conflicts that we have. Sometimes they are valid, you know, like you are pregnant, you're old, and sometimes is you know, because that you feel that you're not comfortable with COVID-19, okay? So I think at the beginning phase of the pandemic, I think when it comes to SARS-CoV-2 and COVID-19 is a very new virus, and we do not know what's going on. And that's where I think the ID comes in, you know, to figure out things, you know, what are we looking at? You know, they are the best person that they do to actually manage COVID-19. And now it's been a year, and I think there is enough of information that they have been sharing. You know, they have been trying to say that, you know, we could try and manage on our own as much as we could. You know, the complicated cases will definitely go to them. So it's good to actually kind of, you know, look at your patients as a whole. And I think what we are fearing about and what we are looking at this point of time is that there are many patients which has other comorbids as well, which needs attention. And somehow they tend to be COVID-19 positive at the same time. And we are, you know, most of the time, the way that they are deteriorating or the way that they're presenting is not due to COVID-19, but due to other comorbids that they are having. And so when we kind of put them to, and referring them to the COVID-19 hospitals or wards, and those care would definitely get compromised, one thing. And second, sometimes when you are doing that referral, is it because, I think the misconception that we have that sometimes when we send patients to Sungai Buloh and we think that the ID is there, and we need to remember the reason that we are sending is because of isolation. You know, that isolation and the containment of that pandemic is not only just that disease, you know, that the experts are there. So I think that plays into the whole holistic view of, you know, how you're going to manage the patient in front of you. You know, I think you should always consult if you have a question.
Yeah, I think so. I think to put it simply, I think if we have patients who are, you know, COVID-19, I think it depends on how bad they are. You know, some of the patients, of course, as we know, having very complex pneumonia, complicated pneumonia, stage 4, stage 5, they certainly need special care. That's when they need to be referred to, not about just ID, but also the intensivists, you know, where they have that support and the expertise. But I suppose some patients, when they are not very severe, you know, some of them, you know, they may be managed in hospitals in setting where, you know, you don't necessarily need a hands-on infectious disease, you know, as consultant, yeah. But you need their input, and of course, they set the standards, and of course, you know, we consult when we are in doubt. And I believe there are many such patients, as you say, they need the isolation. They are treated in what we call pusat kesihatan, pusat rawatan, low risk, yeah, not necessarily in ICU. Not all the COVID-19 patients are all that ill. Shall we move on to the next question? Now we have here, should hospitals require resuscitation? If appropriate PPE is not available, or staffing shortages, or less trained, experienced team member. So again, I think this is about, you know, resuscitation when, you know, the capacity, you know, for, you know, the staff, I suppose in this case specifically about, you know, PPE. Not sure whether this is an issue still, but I think there were reports in the early part of the pandemic in not Malaysia, maybe some other countries, that we hear people may not have PPE. And would it be ethical for the healthcare workers to put themselves at risk, you know, to resuscitate patients? What do you say, Dr. Tan?
The first thing is your role. I think this is probably the last question that we have time. I think, you know, so your duty to care is there, because in a society, that's your responsibility, you know. So like how we expect our leaders to do what they need to do, our teachers what they need to do. So as a doctor, the duty for you to actually care for the patient. So when you need to actually fulfill that duty, you know that you need PPE, okay? You need that space, you need some breaks, you need the food, you need, you know, then you should be demanding, you know. That's where I'm going to stand by for you to actually demand those PPE from your managers, from your leaders, and saying, you know, we need this, we need this, we need this. So it's your job to actually provide that care, and at the same time, you need to tell, you know, your your administrative that this is what I need to make sure that I would be able to fulfill my duties. So that sometimes that role, right, the responsibility is not just the clinicians, but also the reciprocal obligations of healthcare leaders to make sure that you could do your work best. So, but you could not say that, you know, I don't have PPE and I'm not going to do anything about it. And I just decided, you know, not to see the patient, and that would be wrong. Okay.
I think so. I agree. I think, of course, in the beginning of the pandemic, it's such a new disease. And in China, you remember the days in Wuhan, they were overwhelmed. And I think we were fortunate we were not the first place to get it. And I think the rest of the world, including us, had the chance to prepare. So I think the preparation is the key. I agree with you. And I think this is where we had to, I would say, we had to prepare more than what we think we are going to cope, so that we don't, sort of find ourselves in that situation, that we don't have PPE. I haven't heard that situation yet, but I think whenever we heard at the early time when we had the pandemic, we were able to quickly solve it. We were quickly, get the supplies out to people. And I think, I'm not sure whether you had any issues for PPE shortage, nowadays.
I think for my department itself, we have enough, and I managed to actually secure a few donations as well from, the American companies. And I think there is no issue to actually have that plan ahead.
Yeah.
To be, to plan. I know Dr. Liew, you have been managing quite well, and,
I think we all try to plan ahead as much as you said. Yeah, shall we move to the next one then? Now, this is a question. I think this question came about before your talk. So, but I think it's good to recap. What type of patient should we decide, or should we consider for do not resuscitation?
It's been covered.
It's been covered. Yeah. A quick recap. Well, as we say, we think that the benefit of resuscitation, outweighs the need, and then I think you consider it. You start to think about it, then you should consider it. There's a little voice in us that tells us that I think I've done my best, and I think this patient is not likely to make it. We shouldn't see dying patient as our failure, as I always say, but to recognize that is important, and to recognize that. Addressing good end-of-life care, I say, is step-up care. We need to rebrand it. We shouldn't say it's step down. I've been telling colleagues, and I say we should brave enough to tell people, cure sometimes, care always. And time to tell people we've done our best. And I think, people expect that for doctors to be honest and to be caring, to be caring till the end. That's how I look at it.
And doctors need to take breaks as well, Dr. Liew.
Okay, shall we move on to the next question?
Yeah.
Look at the question. You can see the questions there. So we have, should hospital require, no, we done that one. Why different vaccines for different people? Efficacy is not the same for all. We all know a tough one to choose. Some countries allow choice. This is nothing to do with the topic of the day, but would you like to comment on it, or shall we move on? It's about we need a different webinar for this one. This is about vaccine.
I would say the last thing we should be doing just now when we were talking about is dramatizing.
Yeah, I think we leave that now. If we have time, we may want to make comments. Let's move on to the next one. For humanity, can we allow close spouse and children do the last respect visit upon request? And what are the precautions will be recommended? So I think
one part, we are going to be drafting as well.
Yeah. So do you want to make some comments on that?
I think there is one certain group that we should be considering are those which are dying. But again, when you have a population or community which is in the red zone and anybody could be COVID positive, and that there is another concern in terms of infection control, allowing them to actually come in. So how do we balance that? So I think it just needs a bit more planning, how you want to screen and, allow and signing a consent for risk, transmission. So I would say that it's something that could that can be done. Like, overseas has been opening for, those that are dying. Yeah, but yeah, I think it needs to go back to hospital administration and to look at the feasibility of, the whole thing in terms of infection control. Yeah.
Okay, great. Thanks a lot. So it's 4:49. We already passed the time, and I think we have to wrap up here now. So I think once again, I'd like to thank Dr. Tan Hui Siu, and of course, we had to thank our ICR and all the other parties who is involved in setting this, setting up this webinar. I think it's a very important topic, and I would love to hear from you more. I'm sure we'll find opportunities where we can share this with different clinician groups. And as you mentioned, I think when we deal with cancer patients, in some way, this topic is sensitized. But when we deal with non-cancers, especially chronic illnesses, or for times like this, acute disease, even in some people who may be previously healthy, the issues of dying and the need to address do not active resusc, or in that manner, end of life care as a bigger context, as you say, is a very important aspect of being a good clinician. I wouldn't spend too much time. I think maybe Dr. Tan, any parting words, any last message you'd like to share with us?
Keep the conversations up and going, and I think that's important to acknowledge the struggles that we have. Yeah. Regardless of the answers that we might agree or not, with each other. Yep.
Okay, I think with that, thank you very much. I think everybody have a good day and be safe, as we say. Okay, thank you very much again. So we'll wrap up this session. Okay.